Welcome back to Long Covid Doctor, an educational series for long Covid sufferers. I'm Dr. Tim Robinson, formerly a family doctor, GP for 30 years, now working in Long Covid Services for 5 years. I post on podcast channels and YouTube. I hope you find them helpful. If you do, click subscribe, spread the word. Thanks for any feedback. Apologies, no replies, no time. I'm so sorry. I read them though. I appreciate them. Keep them coming. They help me with my future postings. Another apology, my usual disclaimer. It's important. Any advice or treatment I mention should only be considered after talking to your own doctor. So here we go. This talk is on Mast Cell Activation Syndrome, MCAS for short. MCAS in Long Covid. I've divided the talk up into 2 parts to make it less overwhelming and less tiring. So first of all, part 1, I will cover the symptoms, the causes of MCAS. And in part 2, I will cover the treatments and strategies to help MCAS. So here we go. MCAS in Long Covid, Mast Cell Activation Syndrome. So, mast cell activation, i.e. activation of mast cells, and a syndrome. Yes, what is a syndrome? A syndrome is a group of symptoms that make up a condition. So first and foremost, question, what is a mast cell? Basically, a mast cell is one of the many cells within the innate immune system, the first line defense of your immune system. Other cells in the first line defense would be cells you might have heard of, macrophages and natural killer cells, which are a type of lymphocyte. Basically, mast cells are throughout the whole body. All the body tissues contain mast cells, okay? But the gut, respiratory tract and skin are the 3 areas, parts of the body, that mast cells are particularly densely populated. And they contain what's known as pro-inflammatory factors. So these are mediators of inflammation. They basically enhance inflammation. And any one mast cell will have up to 1,000 different mediators, these inflammatory factors. The inflammatory factor in greatest sort of volume and presence within a mast cell is histamine. And then finally, mast cells are basically larger cells, and on the surface of those cells they have receptors. Okay, these receptors are the histamine 1 and 2 receptors. Histamine 1, H1, histamine 2, H2 receptors. There are many other receptors as well. And a receptor is a sort of like a lock and key principle. So it is the lock, okay, in which a key will slot into it. Okay, and I'll come to that in a minute. So that's what mast cells are, and that's where they are, or that's where they are, what they are and where they are. But what do they do? Mast cells basically defend us against invading viruses and bacteria. Okay, viruses and bacteria lock into this receptor that I've just explained, the lock and key principle. So in a way, the virus, the bacteria, is the key that slots into the lock, the receptor lock on the membrane lining of the mast cell. When that key goes into the lock, when the virus goes into the receptor, the cell membrane breaks down. It opens up, if you like. When it opens up, it releases the contents of that mast cell. And like I said, inside the mast cell, there are up to 1,000 inflammatory mediators, of which histamine is in the majority. So those mediators, and in particular histamine, is released into the surrounding tissues. Okay, so what happens when all that histamine is released into the tissues? What are the effects of histamine? Well, as I said, the majority of mast cells are in the gut, the skin, and the respiratory tract. So let's think about each in turn. What effect does histamine release have in the gut? Well, in the lower gut, in the lower intestine, that can lead to a change in bowel habit, semi-form motions, more frequent motions, also colicky abdominal pains, like in irritable bowel syndrome, and bloating and distension and excess gas. In the upper gastrointestinal tract, the upper gut, that can lead to indigestion and heartburn and discomfort in the top of the abdomen, what we call the epigastrium. Another effect of histamine in the gut is food intolerance and sensitivity. Patients are reporting to us that they've always been able to eat everything, but since having COVID, that has become long COVID, they've also developed intolerances to typically wheat and dairy, and then that leads to those symptoms of loose motions and indigestion, etc., etc. So those are the effects of histamine within the gut. What about in the skin? Well, patients are presenting to us with hives, urticaria, so sort of blotchy rash that comes and goes and is extremely itchy. Patients are always also presenting to us with generalized itchiness, what we call pruritus. Also flushing and also burning sensations in the skin. And then the respiratory tract. Patients are presenting with an interesting sort of combination of symptoms, and mostly upper respiratory tract. So congestion in the nose with secretions, sinus congestion and fullness and discomfort, a postnasal drip, sort of, mucus and catarrh going down the back of the throat, and sneezing, and sometimes even wheezing. So in a way, this is beginning to sound a little bit like hay fever, isn't it? And then the wheeziness is a little bit like asthma. Other symptoms, having covered the skin and the respiratory and the gut, other symptoms occur because of histamine affecting other tissues. So the muscles and the joints contain lots of mast cells in their connective tissues. And when they are triggered off, then that brings about pain. There are mast cells in the brain tissues, throughout the brain tissues, but particularly in what's known as the limbic system, so the emotional and the memory system. So that leads to brain fog. And then a lot of patients are also describing sort of feeling lightheaded and sort of feeling their heart, the sensation that they can hear their pulse in their ears and feel the heart beating in the chest, palpitations. These are dysautonomic symptoms. And this is because there are lots of mast cells in the brain stem, the area that controls the automatic autonomic nervous system. So that if the mast cells are triggering in the brainstem, that causes dysfunction of those, what we call nuclei in the brainstem, that control the autonomic nervous system. And so it becomes dysfunctional autonomic nervous system, otherwise known as dysautonomia. So those are the presenting symptoms of mast cell activation syndrome. Those symptoms go together as a picture, a combination of symptoms. And like I said, the definition of a syndrome is a combination of symptoms that suggest a condition. So this combination of symptoms suggests the condition of mast cell activation, and that's why we call it mast cell activation syndrome. That's the diagnosis based on those symptoms. A lot of people ask, well, can't we measure it? Can't we make the diagnosis on lab tests, on laboratory tests? Can't we measure something? Well, yes, we can measure aspects and elements of the mast cell components, okay? So, for example, we can measure tryptase. We can measure another component called chromogranin A. But both are not that reproducible and not that reliable and lead to false negatives. So tryptase is a common one that's requested, but in actual fact, tryptase is only elevated in severe anaphylaxis. And in order to detect it, you have to take that blood test within 2 hours of anaphylaxis. So anaphylaxis is severe, sort of extreme allergic reaction. Okay, allergic reaction. If you take the blood test greater than 3 hours, then the tryptase level has dropped down to normal again. So in a way, it's a false negative, even in the context of taking the blood for anaphylaxis. In mast cell activation, you're not going to get that peak of tryptase elevation and release. And so actually, a tryptase level that comes back negative doesn't really tell us one thing or another. It doesn't confirm that you might have mast cell activation or that there has been some sort of adverse event that has led to dumping of tryptase into the circulation. So basically, blood tests looking at markers for mast cell activation really aren't that relevant or helpful. And then you can actually send urine samples off for breakdown products of histamine. Sounds like a sensible thing to do because the problem is to do with excessive histamine in the tissues. So let's see if we can sort of look to see whether there are excess breakdown products of histamine in the urine, which you can do. And also you can you can also send the urine specimen off for prostaglandins and leukotrienes, who are basically inflammatory components, part of the inflammatory reaction process as well. So you can do that. It's a 24-hour urine specimen, which is not that difficult to do. It has to be then frozen. It has to then go to a specialised lab. So the long and short of it is actually, these tests are not overly helpful. They're not routinely requested, and they're not widely available. So the long and short of it is that actually, yes, we can measure something that may point towards the diagnosis of mast cell activation syndrome, but in actual fact, in the real world, in reality, those tests are not very helpful. So therefore, it does come back to making the diagnosis on the combination of symptoms. And then we confirm the diagnosis on the response to mast cell activation treatment, which I will come onto in section 2. So, what should we do? Well, first and foremost, what do we do when we develop any symptom that's out of the ordinary, which is indicative of something's not quite right? We go to the doctor, don't we? Okay, we report something new to the doctor and ask for help, ask for explanation, ask for help, and maybe ask for treatment. The reason why we do this, rather than just sort of carry on and sort of try and sort of put up with the symptom, is that we don't want to be COVID blind. We want to report that symptom to the doctor so as we can exclude other causes for that symptom. So, all because you've got long COVID and you've got this new different symptom, it doesn't necessarily mean they are associated. They may be just coincidentally there at the same time. We don't want to explain symptoms away to long COVID, not having excluded other causes for those symptoms. So safety first. Go to the doctor and tell the doctor what is occurring. The doctor will ask you all about your symptoms, and basically probably want to do an examination. The doctor will probably ask about other past medical history that you might have. So, for example, I talked earlier about the effects of histamine on the respiratory system. Sounded a bit like hay fever, didn't it? Well, maybe you've got a past history of hay fever and the hay fever's worse now. Or likewise asthma. The doctor will ask him or herself, basically, is your asthma optimally controlled? So may adjust the treatments, etc. What the doctor is also doing at the same time in the whole process is ruling out any symptoms and signs which are worrying. Okay, symptoms and signs, red flag symptoms and signs, which could be indicative of other conditions. So remember what I said about the mast cell effect or the histamine effect in the gut. Well, it causes a change in bowel habit. Can do. Well, there are other more sinister reasons for a change in bowel habit. It could be because of inflammatory bowel, or it could be, say, a bowel tumour. So we don't want to overlook those other causes and just sort of put it all down to long COVID mast cell activation. We want to exclude those other causes first, so we don't overlook them and hence not action them sooner. In this whole process, if the GP has sort of teased out various symptoms, the GP may say, those upper respiratory symptoms, those hay fever-like symptoms, well, let's see how you respond to hay fever type treatment. So antihistamines, for example, or nasal steroids, or a topical steroid if you've got some sort of skin, eczema-like rash. Likewise, gut symptoms. If the GP hasn't detected any red flags, the problem isn't that great, and the symptoms sound a bit like irritable bowel syndrome, the GP could prescribe at that time mebeverine, for example, or peppermint oil. So, I've sort of talked at length about the causes of MCAS, Mast Cell Activation Syndrome, and the effects of it, the symptoms you're experiencing, in a way to sort of bring it all together and see it as a combination, like I said, a syndrome, as opposed to all those different symptoms in isolation, okay? I'm looking at a sort of a general overview of what is happening and giving that explanation as to what mast cells are, what they release, how they release things, why they release things, and the effect of those things they release, helps us sort of understand the whole process, which gives some validation to the condition. And everything I've said is, if you like, backed up by research. So what you've got is not imagined. It is not in your head, not all in your head, no. Knowing all that, it gives you, helps you with acceptance of your condition and sort of peace of mind, consequently. But more importantly, it helps guide the management of the condition of the mast cell activation syndrome, and helps, the doctor, us, to be able to advise accordingly in order to dampen down these annoying symptoms. So that's what we're in the business of. So there we are. That's part one of my talk. Mast cell activation in long COVID, what our patients are experiencing and their causes. So in part two, I will talk about how we're going to tackle them, the treatments and the strategies. And so, without any further ado, I will look forward to seeing you there. See you there.